Let's continue along the framework of T-stage classification, but I want to focus for a minute on pathologic classification, the so-called PT staging, P standing for pathology. Now, why do I want to show you this? My goal is for you to have a framework of what's important so you can go back and correlate and see how well you're doing, what the MR missed or made, and even going forward. If you have a biopsy and you have a follow-up MRI, this will help you make an appropriate correlation. There is no, by the way, pathologic staging that correlates with the clinical and or imaging staging in these early stages from TX to T1C. And in fact, there's no imaging correlate from TX to T1C. So PT2, pathologic T2, the cancer is confined to the organ. In other words, I'll take the cancer and make it deep red or maroon. The cancer stays inside the prostate. It doesn't go outside this capsular margin. PT2A, there's unilateral involvement of 1/2 of one side or less. So we might have something like this, but it doesn't involve the other 50% below down here. PT2B, there's unilateral involvement, but more than 1/2 of one side, so the volume of involvement is greater than 50%. That's very straightforward, but there's no contralateral involvement of the opposite lobe. Bilateral disease, the opposite lobe is involved. It's self-explanatory, and we have midline crossing. Extraprostatic extension, PT3. We've got PT3A, extraprostatic extension, or microvascular invasion of the bladder neck. Now, this is macrovascular invasion, which we're good at seeing. Microvascular invasion, not so much. Now, in patients with microvascular invasion, a positive surgical margin should be indicated by an R1 descriptor, which means residual microscopic disease. But that's a pathologic designation only, not imaging and not clinical. Then we have PT3B, seminal vesicle invasion. The seminal vesicles, which we'll draw here in, say, blue, kind of coming off to the side. And MR is excellent, even without DCE or dynamic contrast enhanced MRI, at picking up seminal vesicle invasion. And finally, PT4, invasion of the rectum, levator muscles, and or pelvic side wall. Now let's talk about more distant disease, just for pathologic staging, not for clinical staging, not for imaging staging. We've got PNX, regional nodes or not sampled. PNO, no positive regional nodes, and PN1, metastases in the regional nodes. Very simple. And you see the distant metastasis staging, which is not necessarily pathologic, that we'll discuss separately. We'll have a link for this on your MRI online, visualization of this vignette, so you can click over and look at some of this information in static format. Let's move on, shall we?